I would like to introduce our next two speakers. Amee Patrawalla, MD at Rutgers, New Jersey Medical School in Newark, and also Connie Haley from the Southeastern National TB Center at the University of South Florida. They will talk to us about diagnostic challenges. Please go ahead.
Thank you, Max. This is Connie Haley. I'm going to present the first case. So for the first case, this is a patient that we were consulted on who is 46 years old. She was born in the Gambia, but she's been living in the United States for 12 years. Her sister died of tuberculosis when they were together in the Gambia. She has possible multiple sclerosis that's being treated with interferon. She also has migraine, anxiety, depression, and possible fibromyalgia. She presented initially with a cough, weight loss, fatigue, and malaise. And on chest x-ray, she had a right upper lobe cavity. So my first question for Angela and Marie-Claire Rollinson, I'm not sure if we introduced her initially. She is going to be one of our guest panelists because she is stepping in for Bev Metchcock, who I think everyone knows and wasn't able to be with us today. Marie-Claire is the director of the state of Florida Mycobacteriology Lab and also is very involved with a significant leadership role in APHL. So ladies, how in this situation with this patient, would the lab be able to help us decide if this patient needs to be isolated in a healthcare facility?
So I guess I'll take a first pass at that. So I mentioned the NTCA APHL consensus statement and the predictive nature of negative expert MTB RIF tests, as you have there in your first bullet point, and that those are predictive of 1 or 2 negative experts or predictive of 2 to 3 negative smears. So I think, obviously that's a good first step, the combination of smear and expert in this case. Then I see you've listed out there some different results. Do you want me to kind of walk through those?
Yeah, please. I put them there for later, but I'd love for you to talk through it. Okay. It's just a big question people have.
Yeah, absolutely. So if you have an AFB smear positive sample and then your results from the gene expert show that it's positive for Mycobacterium tuberculosis, in that particular case, just as listed here, it's highly likely that you're dealing with a case of tuberculosis. And obviously, Connie, you can speak to the continuation of the airborne isolation.
Whenever I see a smear positive and it's confirmed tuberculosis, to me, positive smear means a higher likelihood of infectiousness. And so I would definitely want to keep that patient in isolation because they are in a healthcare facility. Or if they're at home, they would need to stay in isolation, but this is really a tool for saving money in healthcare facilities. So it's not really criteria that we look at specifically in the home as well. Go ahead. And then what if it's smear positive, but the expert was negative for TB?
Yeah, so, in this case, I think we have to talk about the importance of good quality specimens and how that is so critical to getting, good results for these tests, in addition to this third bullet here about it being smear and expert negative. So, in this case, if it's smear positive, but it's expert negative, you're likely, potentially here dealing with non-tuberculous mycobacteria and not necessarily Mycobacterium tuberculosis, but I think it might be a good practice to look at a second specimen from that patient just to confirm.
I agree. For clinically speaking, if you're the infection control practitioner and you're making a decision about taking a patient out of isolation, I think you want to be more certain, just in case there's some reason why the first one was, was falsely negative for detecting TB. But, honestly, that's very rare, and most often, even one specimen showing that it is negative, it is not detecting TB in the setting of there being visible AFB on smear suggests that those AFB are due to another organism than MTB.
Yeah. And then for your third one here, I think it's really important to reiterate that in that particular case, you cannot rule out tuberculosis. As I mentioned earlier, culture is still our most sensitive method. So this really comes down to clinical decision making.
I agree. And as you mentioned, the quality of the sample is very important. And, you are in a healthcare facility, and, we definitely have patients who are not able to adequately produce a sputum. They may end up getting a spit. They're, perhaps if they've had induction, it's very, very watery, but even that would not, if there's TB present, hopefully you could pick it up. But we have a lot of patients that are also culture negative or become culture positive, even though they're smear negative. And probably those patients are not very infectious. But again, when you're talking about a healthcare setting, and I think when both tests are negative, you really want to think about, what are the ramifications of taking that patient out of isolation if your clinical suspicion is still high for TB. Now, if you think it's very unlikely this patient has TB and it was, sort of a light rule out, I think in that circumstance, many clinicians would feel comfortable saying this patient does not need to be in isolation. So you have to always look at the test results in combination with the clinical picture and the patient that you're getting the test result from. Tell me about discordance. What if one set, the first one you order tells you one thing and the next one tells you something else?
That's a very good question. I think you could test another sample. I think I'm making some assumptions here with these results that you're testing the same sample. So that might be, a question as well. Are we testing different samples by smear and expert? And that might be another thing to consider. But testing of another sample, but I think in that particular situation, I think again, it's going to come back to the clinical decision making based on what you're seeing in the whole picture, because the laboratory results are one tool in the toolbox.
Yeah, for sure. I'm going to ask Marie-Claire this question. So Marie-Claire, can any TB nucleic acid amplification test be used for this type of thing? I mean, tell us a little bit about lab developed tests or LDTs.
I mean, really this guidance was provided speaking specifically about the expert, but there are, of course, other nucleic acid amplification tests available, certainly as lab developed tests, that could be used in the same way, and I think would be acceptable in that situation. So although the guidance specifically refers to expert because that's how the data was collected to develop this guidance, other NATs would still be useful in that decision making. And then just, second everything really that Angela said about the importance of using the lab results in the context of other clinical information.
Yeah, that's great. And I just want to highlight that I put a couple of references down at the bottom of this slide for people who want to look at some of that data. And, one of the most important messages I think that we want to pass off is not only is it really important to work with your lab about what the results mean, but, it's really important for clinicians and infection control practitioners and hospital administrators to work with their lab on what do we need clinically to be able to manage patients and even save costs. And the lab, you could talk to the lab and it could say, hey, there's this gene expert machine that could be purchased. They're not terribly expensive. And once you have it, the machine could be used for many different reasons. But, for this purpose, it could be used to help make isolation decisions and rule patients out of isolation sooner, which actually has been shown to be quite cost saving. And you can look down at that reference. I believe it's the Marks and all one. So, it really is a team, and the lab can play an important role in more than just patient care. So I want to move on now and talk about the same patient and the fact that we now need to make a treatment decision. We want to look at the initial smear and molecular test results to decide, does this patient need to be treated? And I really do hope that this webinar series, this postgraduate course, helps you all to understand molecular testing is now the standard of care. It's been recommended since 2009, as Angela said, and the gene expert's been available since at least 2013. And yet so many patients, as you recall from that slide she showed, Angela showed, a third of our patients are still not getting molecular tests on the front end. And that means delayed isolation decisions, delayed treatment decisions, and often inappropriate treatment being provided. So I really think we want to highlight that during this session. So ladies, would you treat a patient, or what would you advise your clinician who is expert MTB-RIF positive for TB and negative for mutations? What does that mean?
So the gene expert looks at a specific area within the RPOB gene, and this goes back to sort of that understanding how these tests work. The specific area that it's looking at is called the rifampin resistance determining region. And most of the mutations that are associated with rifampin resistance are found within that area. So rarely, and we'll talk about this, I think, in one of the case studies, we do find mutations outside of this area, the rifampin resistance determining region, but most mutations you would see within that area. I think you have there that, you know, the assumption here about risk susceptibility, I think that's probably pretty valid, but you would want to make sure that you're following up with culture. And if there is any reason, any suspicion at all in terms of what you're seeing with the clinical picture, this is certainly, you know, that's a situation where you would want to get an MDDR test or some service similar to that to take a more detailed look at sort of what might be going on.
And just from a clinical standpoint, I want to highlight that the RPOB mutation is the most important to us because without rifampin or without a rifamycin, you're committing the patient to treatment with you know, prolonged treatment course of anywhere from, you know, 12, 18 to 24 months of therapy, often using other drugs that may not be as effective. And if you remember, you know, rifampin is so important and is able to shorten treatment because its activity is not just against the actively replicating organisms in the initial phase when you're hitting it hard with 4 drugs, but it's also, it's very good at sterilizing the latent or semi-dormant organisms. We call them persisters that, you know, are not actively replicating. And so you really have to have drug around when they, you know, wake up if you're relying on a cell wall active agent. But if you're relying on, if you have rifampin, it can actually kill those persisters and it enables a shorter continuation phase. And you know, the other thing about treating, if there's no RPOB, you can assume it's RIF susceptible and you are starting 4 drugs. And that's really kind of why we start 4 drugs. There may still be INH or even PCA resistance, but you know, if you've got 4 drugs on board, very likely that you're covered until you find out. But if you don't do these tests on the front end and you find out weeks or months down the road when the cultures grow, you're behind the 8 ball already. And so if we were to have a patient that is MTB RIF positive for TB and positive for that RPOB mutation, you know, I'll just go ahead and say, you know, in that situation, I wouldn't immediately start treating as RIF. I would get that MDDR exactly like Angela said, because then you need to know more. You know, you don't want to just randomly choose a regimen. And we know enough now with molecular testing that we have the ability to define exactly what other mutations are present and kind of give us a hint weeks before the culture comes back as to what we might choose for treatment. So what about if the test is negative? Or particularly if someone just says, oh, the expert's negative, you know, what does that mean?
Connie, I was just going to add on to what you said on that last point, just before we moved on, that, you know, when we look at the expert MTB RIF assay and we see RIF resistance, what this assay is really doing is providing an MDR multi-drug resistance screen. And the reason for that is that we rarely see RIF monoresistance. So we do see it, but we much more commonly see rifampin resistance with isoniazid resistance. So this kind of speaks back to the ideal algorithm that Angela presented earlier that was showing that a test that is an MDR screen ideally should be performed as early as possible to get that MDR diagnosis.
Yeah, you're exactly right. I mean, it is rare. I mean, you have seen RIF monoresistance and they do both get treated the same way, but you know, regardless, finding additional information with that full MDDR screen or sequencing, as you all have said, is really critical. So one of the things that just, if the test is negative, what does that mean? And you know, comment a little bit on the language. Like, you know, if someone says, oh, the expert is negative, I think that could be misconstrued.
Well, I think if you just got a report that said the expert is negative, my next question would be negative for what? Because there's 2 questions that you're answering with that test. You're answering is TB present or not, and is RIF resistance detected or not. So I think you'd certainly want some clarification on that answer. But in this case, negative for Mycobacterium tuberculosis as I mentioned earlier, you know, although a very good test, it's not as sensitive as culture, and it has different performance characteristics in smear positive versus smear negative samples. So I think what you have there is exactly right, that it does not rule out the presence of Mycobacterium tuberculosis.
You mentioned the limitation of the gene expert, and in our lab in Florida, we actually will screen first with the real-time PCR because it's more sensitive, I believe. Is that correct, Marie-Claire? Can you kind of describe why some labs would do you know, something to see if TB's there before they even look to see if there's resistance?
Well, I mean, we do a NAT in Florida, and it's a lab developed test, and it is highly sensitive. But I think one of the other advantages is that we have validated it in our lab for multiple specimen types. The Expert MTB RIF assay is FDA cleared for sputum specimens only. So, you know, that I see there's actually a question in the chat that kind of it's asking something similar to this question. The question from Ian is, given that there are NATs which give resistance information, is there still a place for PCR alone, or should labs move to expert or related tests? And I think the key here really is whether you decide to do expert or a lab developed test, which is, you know, a PCR alone, for example, as long as you then have a molecular test to look for resistance would be key. And that, you know, going back to that ideal algorithm, you're able to rapidly do an MDR screen.
Yeah, unfortunately, as a clinician, I see far too often that they detect TB with just a PCR or NAT and don't go that next step. And that becomes problematic when RIGO started, you haven't ruled out rifampin resistance, and then the cultures come back and it's a surprise. And perhaps there's, you know, INH and RIF only, and now you've treated them, and now perhaps you've acquired additional resistance with PZA or EMB because you've been only on 2 drugs. And so, you know, it really is important. You know, I know that resources are a limitation, but this is another circumstance where I would say, as a clinician, you know that you have perhaps a certain number of high-risk patients in your jurisdiction. You know, the most common would be patients born in high-risk TB endemic countries, but also patients who've been previously treated, patients with HIV or risk factors for malabsorption. Those are really where you want to be certain that, you know, the gene expert is done. And, you know, it's just important that you try to get that technology. And if you don't have it, then know where you can refer your sample that shows it's TB, but they're from, you know, Peru or South Africa. And, you know, rather than waiting 4 weeks for the cultures to grow, you want to know right now how to treat them. And remember, TB is almost never an emergency. These patients have had TB for weeks, if not months, sometimes even years. And so another couple of days to make sure that you're getting the right diagnosis is really important. So we've talked a little bit about, tell me just a little bit about, you know, the smear negative. Does the lab automatically do testing on all respiratory specimens that are sent? If it's a protocol that says do NAT, do you have to ask for non-respiratory specimens? I'm sorry, you have to ask for smear negative specimens, and then also talk a little bit about non-respiratory specimens, please.
So I'll start with that. I would say my experience with the public health laboratories that we primarily correspond with, the most common algorithm that we see for NAT, nucleic acid amplification testing, is new smear positives and smear negatives on request. Some laboratories do perform universal NAT, but not all. And so I think it's one of those things that you would want to understand, at least in the public health sector. In the clinical sector, I think you would need to request it.
Mm-hmm.
So Marie-Claire, if you want to add to that.
Yeah, I mean, I think it's kind of a complex because many labs have different processes. I know some, you know, large academic medical centers where only ID physicians can order, for example, a NAT on a smear negative sample or a NAT on a sample that's non-respiratory or things like that. So usually, you know, different labs kind of have different caveats as to when the testing is performed and when, you know, a specific request needs to be made.
Yeah, and that's a clinical point. I think, again, you know, communicate. If you're a clinician, order whatever it is that you think you need to make the right diagnosis. And if you're thinking TB, be sure and say, even if the smear is negative, if the PCR is positive, that will help me. The yield is going to be much, much lower when there's fewer organisms and the smear is negative. But you do sometimes find a positive, which again, makes the diagnosis sooner and may enable molecular resistance testing. Could one of you talk about non-respiratory specimens and what testing can be done for that, and perhaps the FDA approval issue?
Yeah, I mean, I'll just jump in here as a lab that does a lot of testing on non-respiratory samples. Now, as I was saying, different labs have different rules, but in our lab, essentially, anyone can order a NAT on a respiratory sample, but if it's a non-respiratory, it has to be approved. There are a couple of exceptions, and these are examples that we consider sort of high consequence specimens. And the two examples would be CSF, where there is a concern for TB meningitis, and the second would be a gastric aspirate, where there's suspicion of TB in a pediatric case and a sputum sample can't be obtained. So it really depends on the specimen source, but we in our lab have validated a range of samples for these reasons.
I would just add to that I think this goes back to that conversation about speaking with your laboratory, understanding what services are available, and also understanding what services might be available through referral.
Yeah, Angela, one of the questions is, what does my lab do if it doesn't have expert? If you have a lab and you get a NAT, just a basic NAT, like a lab developed test or the Hologic, although you said it's going away, and they're really suspicious of MDR-TB because, again, either previously treated and now they have a relapse, or because they're from a high TB endemic country, can they call CDC and get an MDR, at least get some preliminary testing from you, or do they need to try to find somewhere else to send a test for that?
So if the specimen or the processed sediment is known to contain Mycobacterium tuberculosis because of a positive NAT that was performed, that is certainly acceptable for submission for MDDR. We would take those. You do not have to wait for culture to grow, and you do not have to have information about rifampin resistance. It doesn't have to have been detected by expert or any of that. We take, as I mentioned in the presentation, we take samples for a multitude of reasons. So we would take a NAT positive sediment and we would take a culture isolate that has Mycobacterium tuberculosis. Both are acceptable.
Talk just a little bit, and this last bullet was, wait for the culture. Are you only doing MDDRs on the culture growth? And I think that Marie-Claire and I do a lot of teaching in the Southeast National TB clinical course, and there seems to sometimes be confusion between the clinical specimen and the culture isolate and which tests can be done on which.
Yeah, so for our MDDR services, I mentioned both would be acceptable. What we do get questioned about sometimes is that a specimen where there has not been a positive nucleic acid amplification test result, we don't typically accept those. The reason being is because if there is amplification, previously known amplification, then we're more likely to have successful sequencing results, amplification and then sequencing results with our MDDR service. So that's sort of why we've made that designation. But no, both could be submitted. And I would say just call us. We're happy to have a conversation.
Yes, and I've already said this, TB is rarely emergency to treat, and it's just so important to communicate with your lab and to be thinking that even if you don't think it's TB, but then you get, say, a positive smear, or you don't get something else you expected, and or maybe you get, a biopsy and a culture, and anyway, the point is, think about TB and order the right test on the front end. And if you can order molecular on the front end, you're going to, if there's enough TB present to be picked up, you will be so much farther ahead with your patient management, your likelihood of treating them appropriately and avoiding toxicity and curing them. So I'm going to just move on. This patient, just to kind of move on, this patient ended up being AFP positive on the smear. She was also NAA positive. So she was started on 4-drug therapy. she had so many problems that just made her a real challenge to treat. We had to swap her from rifampin to rifabutin for rash and itching. We then had to hold her EMB because of visual changes. We had to hold her, all of her treatment for a prolonged period of about 6 weeks because she had hepatotoxicity, and we just couldn't get her restarted. And so I say we, there's actually a patient that someone else managed, but ultimately it turns out after about 4 months she became culture positive again, and she had been previously documented to convert to culture negative. And so this was a new concern that needed to be dealt with. And so in this situation, how can the lab help us here? New positive culture, what can we do?
Well, I think you would obviously have concerns about potential for emerging resistance. So this would be a good case for sending it for MDDR or a similar type service.
What about the fact that people say, oh, those molecular tests can't be done if the patient's already had treatment?
So I think what that's referring to is things that I mentioned earlier, like the nucleic acid amplification tests. Some of those, according to the FDA cleared package insert, have restrictions on their use if the patient has been on treatment past a certain time frame. I think that would depend, again, on the comfort of the laboratory and for them to do some sort of validation for off-label use. But for MDDR and other services of that type, it would certainly be acceptable.
Yeah, and then Marie-Claire can jump in here too. Often in Florida, they will report things to experienced clinicians who understand the benefits and the limitations of those results. The results may not be fully validated, but there may be some wise clinicians who can interpret them in the context and have enough information to make a decision. Do you want to speak to some of those caveats, Marie-Claire?
Well, I would just say that there is some testing that we do which gets reported to the TB program for public health purposes. So there's sort of some additional testing that we're available to do, but it doesn't get reported out on the patient's report. So that just kind of speaks to that.
So if it's a positive test, it's detecting TB DNA, does that definitely mean that it's an active TB?
No, that's one caveat to keep in mind, is that for nucleic acid amplification tests, they're going to detect nucleic acid, and that nucleic acid would be there with both live and dead organisms. So it's not something that you would use for monitoring response to therapy. Right.
So if it was, say, smear negative and PCR positive, you might be picking up DNA that's dead and has been cleared. It has not been fully cleared from the sputum. But it's possible that it's early and the cultures may still grow, but you have that information though, I think, to make the decision. And certainly if you're smear positive, again, especially in the setting that you're smear negative, and you have a positive NAT, then that's helpful. And I think also if you are smear positive, you have a negative NAT, then it's possible that this culture growth is, it's AFB, but perhaps it's an NTM and not a TB. And so that, it's certainly possible with patients who end up with a lot of destroyed lung. I think that may mean that we're getting close to the end. I think we've covered a lot of this. In Florida, we'll often order in patients who seem to be potentially relapsing, we'll often order either gene expert or something else or even MDDR, because new resistance that wasn't there before is new. If you know that you had a pan-susceptible organism and you've got a positive NAT that says the TB DNA is there, but now you've also got new resistance to INH or rifampin or something else, that it means that something's gone wrong with their treatment. Either they had a mixed population initially and you didn't pick it up, which is not that common, or that the patient, such as this, who stopped and started treatment, may actually have acquired drug resistance. So I'm going to just move on a little bit to get us, one issue we kind of covered already is that when we were working this patient up, the clinician was told by the lab that it was expert MTB-RIF positive, and the clinician said, is it positive for the RPOB mutation? And she said, yes, it's positive for the RPOB mutation. And that didn't make sense. I mean, it was possible, but what we ended up doing was the lab, the clinician called the next day and talked to the lab supervisor. Before we put this patient on a whole new regimen with, harder to take, potentially toxic and less effective drugs, we want to be sure that there really is resistance. And indeed, this was a mistake. There was no mutation at the RPOB loci. The other thing we did here is that the clinician wanted to use moxifloxacin because they've been so difficult. We're going to try to use rifabutin and moxifloxacin. So we wanted to make sure that the quinolone had susceptibility because, many of these patients have just been so experienced with, especially patients who come in and out of the hospital or in and out of the healthcare system, they get a lot of antibiotics. And if the TB is slow to be diagnosed, they often get different antibiotics, including quinolones. And so we're starting to use the HINE. And Marie-Claire, do you want to just talk a little bit about how we use the HINE? And again, kind of highlight its difference from the Gene Expert.
Yeah, well, because we initially start with a nucleic acid amplification test that's just for TB or not, we will then, if it's positive for TB, then reflex to the HINE, and we'll run the first line probe that's looking at RPOB, CATG and INHA mutations for RIF and INH resistance. And then if we detect resistance there, or there is an additional need to look for resistance and additional drugs, we can run a second line probe. It's also from HINE, and that's looking for the GYR A and B mutations, RRS and EIS, so fluoroquinolones and injectables. So yeah, in our setting, we have found that the line probe assay is very useful because it is a rapid molecular test that we can use directly on the clinical sample, and you can get a lot of information very quickly.
Thank you. And so I'm just going to go on and say that in this circumstance with this patient, we got her back on a regimen that was based on rifabutin and moxifloxacin with linezolid. Her follow-up cultures grew TB and ended up being fully susceptible, and that was great. She does remain a challenge. You all have had many patients like this that, when you have one problem, it becomes another and another, and this is just another reason why communication with the lab is so essential. And we could not have managed this patient without our lab. So I would like to introduce Dr. Amee Patrawalla, who is with the Global TB Institute at Rutgers University. And Amee, if you would like to take over, if you'll let me know, I'll forward your slides.
Okay, great. Thank you so much. So case 2 is a 59-year-old man from Brazil who had no prior history. He had typical symptoms of a cough and weight loss. He did have a known contact currently who had pulmonary TB, and that person was known to be pan-susceptible. However, he also mentioned that he had a brother about 20 years back who had also had pulmonary TB. His x-ray was consistent with upper lobe reactivation type TB and possible cavitation. Next slide, please. So the workup was sent. His initial AFB smear was positive, and expert MTB RIF was performed. MTB was detected, and RIF resistance was not detected. So the patient was started on a standard 4-drug regimen, and he had improvement both clinically and both with his cough and his weight over the next couple weeks. Next slide. Oops, sorry, one back. So this is where the clinician started running into some issues. The AFB culture did report as positive for MTB. Growth-based susceptibility, remember that the RIF resistance was not detected from the expert. However, growth-based susceptibility testing from liquid culture now showed isoniazid, streptomycin, and pyrazinamide resistance. So this caused some confusion. The clinician called the laboratory, and they were discussing, how could this be and what could the possibilities be here. And so there was ongoing communication, but at the time the treatment was also changed based on these drug susceptibility results, and MDDR was sent to CDC. So Angela, Marie-Claire, how would you approach these results, these sort of surprising drug resistance findings? from the lab point of view, and what sort of advice would you offer the clinician?
I think the referral for MDDR in this case was certainly appropriate given the resistance to two of the first-line drugs that you would be using for treatment. I think from the lab perspective, one of the things that we always keep in mind is that drug resistance, although we see it, is still relatively rare. So when you see something like this where you have multiple resistances, you certainly want to try to get additional information as quickly as possible, hence the referral for MDDR. The other thing it would do is trigger, since you have resistance to two first-line drugs, it would trigger the need to test for second-line drugs, because that would be something from the clinical perspective that you might be, you'd be considering what additional drugs you might be able to add.
Great, thank you. So a little bit even more confusing at this point in the case was that the MDDR, which did return quite quickly, returned without any mutations identified. Unfortunately, the culture appeared to be contaminated that had been sent to the CDC from the local lab, and growth-based susceptibility testing could not be performed. However, subsequent AFB cultures at the local lab did grow non-tuberculous mycobacteria, and a repeat drug susceptibility test done on a pure MTB culture was reported as pan-susceptible. The treatment regimen was again adjusted back to first-line treatment. The patient completed their treatment and did quite well. So how did this happen? Can you talk us through a little bit of how the culture methodology here may have led to this, and how can the clinician approach potentially mixed cultures?
So yeah, this is one of those, I guess you could say, limitations or issues with liquid cultures in this particular case, because you don't get to examine the morphology of what is growing in that culture. The recommendation is that a piece of solid media would also be inoculated. And it's for that reason, because you could look at the morphology of what's growing on the solid media, and it could give you some indication of the mixed culture. Mycobacterium tuberculosis is, rough and buff, and so that's pretty characteristic. And if you saw that along with something else growing, it would be a good indicator that you may have, what you saw in this case, a mixed infection.
Thank you.
Is there anything Marie-Claire would like to add there?
No, that's okay. Go ahead.
Okay, great. Thanks. Okay, this is our last case, and it's a really quick one, but I did want to talk to you about this 56-year-old female who's born in Alabama. She has no known TB exposures or TB risk factors, but yet she had a pelvic mass and lymphadenopathy and underwent a hysterectomy and bilateral salpingo-oophorectomy. When the histopathology came back, the fallopian tube had fibrotic granulomas of varying sizes. Some had central caseating necrosis, expanding the interstitium and obliterating the mucosal folds and the lamina propria. You all have had these cases before, of course. It was formalin fixed and paraffin embedded because no one expected this to be TB. And yet the stain, when they got the histopath specimen, was positive for AFB and rare structures suggestive of mycobacteria. And a T-spot was done, which was also positive, suggesting that she perhaps had real TB infection, even though she had no risk. So, Angela, what in the world can we do now that the sample has been formalin fixed and paraffin embedded? Is all lost? Do I have to just wait and treat empirically?
No, I think that there are options available. I mentioned one of the sources here at CDC through the infectious diseases pathology branch. I understand that there are others, I believe maybe University of Washington and perhaps National Jewish as well, that also do this type of testing. This would be after you've had consultation with them, but you see here a report from the CDC IDPD, and you'll see in the comments section there, one of the things that they can do is that if they detect through their immunohistochemistry or
that is what we see. I mean, if I bring up the chat screen,
through their testing that they're doing, someone's not on mute. I'm sorry. Thank you. If they detect Mycobacterium tuberculosis, they will then pass that DNA extract on to us to attempt to get some drug susceptibility test results through our MDDR service. And so, although we're not successful in all cases, it has been quite important in several cases where we have been able to get some results related to drug resistance.
Thank you. Yes, and so we were so happy to have an answer here that this patient did indeed have MTB and all is not lost. And so please remember that. Get lots of consults on patients who've been treated empirically because TB was suspected after a surgery or some other biopsy procedure and the sample had been fixed and they started empiric therapy and then the patient develops hepatotoxicity or the patient doesn't get better, you didn't have drug susceptibilities. And so please be aware that resources is really so very valuable. And we've actually even had a patient diagnosed with leishmaniasis that we thought might have TB. And so, you know, that is really a wonderful resource. We're at the end of this session. We will be providing these slides. There are some resources here that you will be able to see. And just remember that the sooner you can contact your lab and find out what to do, and the sooner you get samples to them, the sooner the diagnosis gets made. It is so worth it to make that effort to go for the diagnosis. I cannot tell you how many times I have found that a patient had an unsuspected TB or an unsuspected resistance or even something else that we were able to figure out by pushing for it and not treating empirically. And it's, you know, it's really, we call it a new day with TB diagnostics, but on the other hand, some of these tests have been available since 2009, 2013, and you know, really need to push for that diagnosis where we can. Here's some information on the IDPB for you. And just as a reminder for World TB Day, and I think, do we want to ask a question before the break? Or do